Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hey everyone, welcome back to Cardiovascular Matters. We've had a really good two or three sessions with Dr. Walker talking about peripheral artery disease in the leg, and we opened up with just a general discussion of the importance of the diagnosis and the simple medical treatments and really lifestyle modifications that you can do to avoid getting yourself in trouble. And then we last week took a little deeper dive into the patients that are often referred to Dr. Walker that have already, kind of crossed over, and they're into the bucket of what we would call critical ischemia, where they've got a really significant blockage. And while you still have to do all the things that we talked about in the first segment of our talk, as far as lifestyle modification, the medications, walking, and all those things. An intervention is in order, and there's just no two ways around it. And I thought Dr. Walker gave a very balanced discussion on the combination of both non-invasive, invasive, interventional approaches, and then also the use of surgery if that is appropriate. But today we're gonna get into another topic of that's even one step beyond the critical ischemia, and that's when a patient presents and they've got acute limb ischemia, and that's where I'm going to let Dr. Walker explain it, but that's kind of where the rubber meets the road in this.
Sure. Acute limb ischemia is it's almost always related to clot. Mm-hmm. And it's when one either just suddenly clots off a bypass graft or a vessel, clots the whole thing off, or they may throw a clot from the heart. They may have an embolic problem.
Right.
Now, the problem with this is that's associated with what's called the 6 Ps. Pallor. That means the foot's cool and it's light colored. Poikilothermia. The foot's cool because it's not getting the blood to keep it warm. Pain. It hurts terribly, because the leg just acutely is getting no blood. Pulselessness. You can't feel a pulse, so that P. Paresthesias. You may lose sensation in the foot as you touch it. And so this is a problem. When this presents, it is a true medical emergency. And many of these patients go on to die. This is very important because what's happened is the leg has suddenly had cessation of flow. There's clot. And clearly, it is important, if we're going to save a leg, to restore that flow as quickly as possible. Every second lost is dangerous to that patient because tissues are dying. Mm-hmm. And as these tissues die, they're releasing things which are really poisonous to our body. As red blood cells as muscle breaks down, we have myoglobin, which can kill the kidney function. We have lactic acid, which is building up in the tissue that's not achieving good blood flow. And in some of those cases, in the worst cases, restoring flow might actually be a bad thing because the patient, you may be washing those things into the patient, causing the patient to acutely decompensate and potentially die. Now, when we see a patient who has this problem, it is crucial to immediately evaluate what is happening. There have been great strides on treating these patients, but one of the first things we would like to do is to do an arterial ultrasound. We look at the blood flow, and we want to determine the blood flow in the arteries. We want to also look at the blood flow in the veins. There are some who have reasonably restored. You can see some blood flow getting through the natural channels in the arteries, and there's good flow in the veins. Those we have a little time to work with. But a patient in whom you see no flow in the artery and no flow in the vein. If that patient is beyond a certain period of time, if that patient has gone more than 6 hours, then fixing that leg might actually hurt the patient because of washout of these toxins that occur with that. Now, still, the vast majority of these patients, if we get to them early, we can achieve limb salvage. Mm-hmm. But part of this is removing clot. Now, historically, that was either surgical embolectomy, where a surgeon gets into the artery, uses a catheter, crosses where the clot is, blows up a balloon, pulls it back, and pulls all of that clot out of the arteriotomy, or out of the hole that they've made in the artery. Now, there are also percutaneous devices that sort of do that same thing, as that was initially created by Dr. Fogarty, a very famous vascular surgeon who helped really change the way that this disease process was created. But it does require surgery, and it doesn't always get all of the clot. The other thing that gained acceptance in the past with the Stiles trial and other things such as that was the use of drugs that dissolve clot. But again, once again, there's a problem. Drugs that dissolve clot, we call those thrombolytics, take time to dissolve the clot. They're not instantaneous. And remember, I said there is a time bomb going off here. Every second is important, and we want to restore flow as quickly as possible. So, albeit these drugs are useful in those patients who still have some arterial flow and some venous flow, really I shy away from those a lot when I'm dealing with patients who have no real detectable arterial or venous flow. I think we have to move this faster. Now, we have a whole series of tools now that allow us to actually remove that clot. We have things which macerate the clot. They go in and break up the clot fairly effectively. We have suction devices that we can use to go in, devices like penumbra or nori, that we can go in and actually suck the clot out. Then we have devices which we can go in with, which are baskets. We go beyond the clot, we open up the basket, and we remove the clot, restoring flow. Now, typically, that is part of the treatment. Typically, you restore flow, but then you've got to figure out, why did you have a clot in the first place? Mm-hmm. If it's a bypass graft, usually the reason is because there was a blockage that had occurred on one end or other of the bypass graft. It may be that this person is hyperthrombotic. There are some patients who are more likely to develop clot. Just like we've all heard of hemophilia or free bleeders, there's a thing called thrombophilia, which are people, if you would, that are more likely to clot. And we know that certain conditions make people more likely to clot. Lung cancer, other forms of cancer can make one more likely to clot. So we want to remove clot. That's part and parcel of this. We want to make sure that we hydrate these patients. We want to make sure we monitor them very carefully so that if some of these toxins are released back into the bloodstream, that we're there waiting for them, trying to make sure that we can handle those problems. But this is a true medical emergency, for sure. And when you go into these cases, you must realize that there's a real chance of death. And this is something that is so crucial, that we get out to patients and get out to healthcare providers, because the key to everything here is to get these patients in the hand of someone who can treat these as quickly as possible. Unfortunately, I often get these patients after days of this happening. And right. Sometimes just the patient stays at home, or sometimes people think it may be other things going on. But when that foot is cool, there is no pulse, the patient is screaming in pain, and almost always this is associated with profound pain. True medical emergency that has to be tapped out. And with appropriate treatment, these patients can actually save the limb and do very well. But it does require appropriate treatment.
I was just curious. patients that have critical ischemia, I mean, it sounds like this can transition overnight, really, if untreated, right?
It can, but some of these patients have no peripheral arterial disease at all.
Oh, wow.
They just suddenly clot off the vessel, or they may
Right.
have atrial fibrillation and have clots in the
Okay.
heart. So some of these patients do not have underlying peripheral arterial disease because predominantly this is clot. Some of these patients may have a problem called a popliteal artery aneurysm, where there's a weak spot in the vessel, and that weak spot is bigger than the rest of the vessel. And so blood flow in that area is not as fast, and that may suddenly clot. The big difference between acute limb ischemia and critical limb ischemia is acutely, or in a very short period of time, things totally clot off. And that's why the presentation is so much more severe, because these patients, because this is occurring so rapidly, have no time to get better blood supply. And we have many, many things that can help us here. You know, angiograms, of course, can help us. The duplex exam can help us. We have many things that can tell us where we are. Now, in some cases, surgeons may actually go in and try an embolectomy or even bypass the leg and go around this area that's obstructed. That's possible too, but it is so important to work these patients up and know why. I've had many patients who've had urgent treatment, and after they'd gotten flow, the thought was, okay, now we've gotten flow. Well, some of those patients were having atrial fib and later on developed problem again, or some of these patients had underlying other problems like a popliteal aneurysm or things which had gone unrecognized. And so I think, the key here is, you'll hear me say this often in medicine, it is not the dramatic, but the blocking and the tackling that matters. It's not that wide receiver running for, a 100-yard pass. It's not that. It's the guys in the trenches making sure little things go right, making sure that I's are dotted, T's are crossed, and making sure that we go through a checklist. What can cause this? And making sure that we find out what it is so that we can address that, and making sure that we ideally restore blood flow. For instance, we have great new drugs that are anticoagulants. But if you're hypercoagulable, or if you're more likely to clot because of a problem called antiphospholipid syndrome, those drugs don't work in that at all. In fact, they may make the problem worse. And so it is very important to make the right diagnosis, even in a class of things, such as, is someone more likely to clot, which antiphospholipid people are, but you have to know if it's that specifically to know not to use other drugs to lessen the risk of clot that simply don't work there. So it's very important to make sure that one makes the proper diagnosis here.
So I'm assuming these patients, most of them, if not, well, all of them, are probably admitted to the hospital, and then you tackle the acute situation going on, and while they're inpatient at that moment, is that when you go back and you start looking at what caused the clot, so that you can create a game plan as to how to tackle that, so that we're not in the same situation weeks from now?
Yes. So, blood tests can help us with that. A lot of the history can, ultimately better angiography and things like that let us understand the anatomy. But I think these patients should have thrombophilia profiles. We should look for arrhythmias. And towards your point, this is not really something we treat as outpatients by and large. And the reason is, if a patient is prone to having a buildup of those things which I've mentioned that can be toxic to the body, then we have to be able to deal with that. That may require urgently being able to administer fluids or consideration of dialysis in some people on a short-term basis, not forever, but some people would have acute kidney injury. So these patients typically are in the hospital for several days. Really, the prognosis of acute limb ischemia, even in today's world, is as bad as a large heart attack.
I believe.
So I've got to say that again, as bad a prognosis as a large heart attack. So this is a true medical emergency, and we have to treat it accordingly. I have something I call the continuum of care. And that continuum of care for me is when do we find disease? And always, the earlier we get to it, the better we can deal with it. And in this case, we're speaking minutes. In critical limb ischemia, we're speaking months or sometimes years. And in simply claudication, even longer than that. But this is really an issue of minutes. And there was in one of the first textbooks of medicine in China, Hudina Chang published this book, and very interesting. He described medicine in a way that I think is very important. And here I'm paraphrasing. He says that the average doctor treats actual sickness. The mediocre doctor treats impending illness, while the superior doctor prevents illness. Now, we can't always prevent illness, but certainly the things that we can do to lessen the risk of progression, and we know what those things are, is very important. But the problem with acute limb ischemia, we can understand it easily if it's someone's had a previous bypass and it goes down. But for instance, if one had an asymptomatic popliteal aneurysm or had asymptomatic atrial fibrillation, there may have been no warning whatsoever. No clue that this patient has a problem. Those people could have clearly had very good pulses in their feet. And so that's why I was mentioning earlier that, if you don't have a pulse in your foot, you clearly have a peripheral problem. But you may still have a great pulse in the foot and have a huge problem. And so it's very important to make sure that's evaluated and that we know what to do with that.
That's great. Well, I hope everyone's enjoyed this information as we've sort of taken a walk down the various pathways that peripheral artery disease in the leg can take. Dr. Walker, I thank you again for all of your experience and expertise. And I know this is helpful for both the patients that are listening and certainly the family members that may be caring for a patient or someone and understand that if this situation occurs, it's important to get them to an experienced specialist who can tackle these issues quickly and efficiently. Be sure and tune in next week, and we'll have even more topics in and around cardiovascular issues, and we'll be featuring Dr. Walker as always. We thank him so much for your expertise and thorough explanation of all these issues that we're talking about. Thank you very much, everyone. Thank you, Dr. Walker.
Thank you, Terry.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.